nicely as well. It's certainly one of the topics that I know they'll want to discuss. So if I could ask John Danesh, the chair from Cambridge, along with Matthew Hotoff, Liam Smith from London School of Hygiene and Tropical Medicine, Kathy Sudlow, and Susan Wallace from the Ethics and Governance Council. Again, my timing is not perfect, John, but I think if we run till about 25 past and have tea a little bit late.
Thanks, Rory. Good afternoon. So I'm John Danesh. I'm an epidemiologist at the University of Cambridge and the Wellcome Trust Sanger Institute. We're going to have a discussion over the next 10 or 15 minutes. We have a lot of questions, which is good. But first, perhaps some of the panelists who haven't had a chance to speak can introduce themselves. Susan, would you like to start?
My name is Dr. Susan Wallace. I'm an honorary lecturer at the University of Leicester and a member of the Ethics and Governance Council.
Thanks. Do you want to hold on to it?
Okay. I'm Liam Smith. I'm a clinical epidemiologist at London School of Hygiene and Tropical Medicine, and I'm also a GP.
Great. Well, the first question, I wonder whether a combination of Kathy and Liam might answer. So it's from the floor. The question is, when will the primary care records be available, and what proportion of UK Biobank will be covered? And Liam, I wonder if Kathy could take that first question, and perhaps you could answer the question about what primary care records are able to tell us that go beyond other types of records, because it is a big breakthrough for UK Biobank to have achieved what Kathy's achieved. But Kathy, perhaps you could address the degree of linkage that's been achieved.
Yeah, so I spoke about this briefly as I whizzed through my slides. Primary care has been very challenging because of the lack of a comprehensive one-stop national source that covers everyone in the population. But we've made significant inroads initially in our partnership with TPP, one of the major system suppliers in England, which has allowed us in England to move towards obtaining linkage for in excess of 200,000 of our 500,000 participants, together with the around about 50,000 who are covered in Scotland and Wales. That takes us to around about half of the cohort. Now, these data are really only just in the process of arriving in our database in Oxford. And I'm looking at Naomi here because she runs the team in Oxford, which has to then handle this huge influx of data, make sense of it, strip it of potentially identifiable material, and work with myself and my team in Edinburgh to work out how we create outcomes from it, health-related outcomes. At the same time, we don't want to prevent the research community from starting to get access to those data just as soon as we can safely and sensibly make them available. So the answer to the question is we will make them available as soon as we can. I think it's unlikely that will occur before 2017, and I don't think we are ready yet until we've looked at the data, which, to be fair, we haven't seen yet. We might have just seen the first few lines of the data. It's going to be difficult for us to say exactly when, but we will do it as soon as possible. In terms of completing the coverage, I think that depends on our work with the other two major system suppliers, which will be technically challenging and challenging from an information governance perspective as well. But we are making significant progress, and I'm absolutely determined that we'll get cohort-wide coverage within the next year or so if we possibly can.
Thanks, Kathy. So Liam, why would that be valuable? Why is that valuable to have achieved that linkage?
Why is it valuable? I think one overall reason is that we're quite unusual in the UK in that the general practice, everyone's registered with a general practitioner, and they really do kind of orchestrate and gatekeep the whole of that person's healthcare. So the primary care record ends up being a very complete record of the patient's journey through anything that happens to them, from outpatients, hospital admissions, to imaging that's done for clinical reasons, to lab tests. And we know that the data in those records are getting better and more complete. We're getting more and more lab results, imaging reports, all sort of things are more available. So it's the sort of totality of the health journey, I think, is a key strength. There are individual, very strong bits of primary care records, for example, the drug data, drug prescribing data. You can basically only be prescribed a drug in primary care through the electronic health record, and so the drug data tends to be very complete and very, very detailed indeed. I think there's a whole scope of a whole range of stuff around methodological research of how best to use these data. That, as we've seen, they've already started with dementia, looking at what can you tell from the primary care record, how good is it? And I think we'll be able to do that for a whole range of different conditions. And it'll tell us really, what we can learn, what we best can learn, when can the primary care data really add to the research, and where is it weak. So I think there's a sort of scope of the whole range of health services, but also there's a kind of plenty of scope to sort of do better research and increase the methods.
Thanks. So the next question is, perhaps, Susan, it's a bit in your territory. It's a question that relates broadly on ethics. And Naomi, you might have some thoughts about this, because I think it's come up in the context of what UK Biobank is considering in its connection with the Dementias platform that John Gallagher, Tim Wilkinson mentioned. The question is, I'm contemplating leaving my body to medical research. Should there be a link between the hospital and Biobank? How do I indicate this to the authorities? So the context here that the questioner might not be aware of is that the connection with brain donation is a live question for UK Biobank. So Susan, could you maybe help us think about the ethical considerations around this before we talk about the planning side of it?
Yes, some interesting questions, and a very altruistic thought on the part of the person that has put this question in. Certainly, there's a question of whether this is, as you say, a future activity for UK Biobank. How would it encompass those kinds of donations into it? There are certainly different laws, regulations on human tissue, et cetera, and this kind of donation that would need to be taken into account, certainly across the countries. And how does the consent work? And I guess, how does this kind of donation merge and mesh into what Biobank's plans for the future are? And how would it need to handle it? And certainly the Ethics and Governance Council would need to do some work, certainly in that area, because as far as I know, we really haven't looked at that. But how do you think Biobank would have that as part of its remit?
Well, I think we would seriously like to consider asking participants about brain donation after their death, for example. We've had some internal discussions about this. But again, I think before we kind of plunge in and just do this, I think we would like to get some advice from the participants, actually, and find out their attitudes about collecting tumor tissue and other types of tissue like brain tissue and other sorts of biopsies. It's a very sensitive issue, and I think before we dive in and just do it, we need to take into account participants' attitudes to collecting that information. But it's something we're seriously considering.
Did you want to come in on this one, Kathy?
Yeah, so discussions around this are probably most advanced in terms of tissue donation after death with respect to donation of brains, where we've had a significant number of discussions with experts in the Dementias Platform UK who've been looking into the ethical issues around this. And we have done some very initial survey work in our imaging participants as they leave the imaging clinic to ask them whether they would be interested in and willing to consider donation of their brains after their death. And we had some interesting responses. So a reasonable proportion, as I recall, about a half of them suggested that they would be interested in this. And in the free text responses, some of them said things like, I'll need to discuss it with my friends and family, which sounds perfectly reasonable, or just make sure I'm dead first was another comment. So this is a very important and pertinent issue, because we know that causes of dementia during life don't necessarily tally too well with causes of dementia in terms of the brain pathology when it's examined after death. And collections that have longitudinal information on what happened during life and collect information on what the brain looks like after death in people who both have and have not died with various degenerative conditions involving the brain are extremely valuable. And so we're very keen, as Naomi says, to discuss this both with our colleagues in the Dementias platform and with our participants to make sure that we do the very best ethically and scientifically.
Great. So next question I might direct at Matthew. So the question is, are there any surveys planned on adverse childhood experiences, life stressful events? And I wonder, in reflecting on that in terms of the questionnaire you developed, which bears on this, maybe you could help address the broader question that was raised at the participant panel this morning, which is, if we take a much broader view of health and view of the social, the economic determinants, educational factors, and given that participants in Biobank have consented to be linked with health and health-related records, what's the potential value of if you like, the non-biological information, particularly for mental health disorders?
Well, I think it's enormous because, for mental disorders, getting measures of stressful life events, your experiences of parenting and early family life, this is the equivalent of sanitation for infectious diseases or smoking for lung cancer. I mean, the associations are very strong. But I suppose I'd argue that it's not just about mental health. And in a way, one of the reasons for, they're studying mental disorders in their own right, but there's also actually thinking about the way in which mental and physical health interact. And, if you look at cardiovascular disease, there's a sort of, a long-standing debate in the literature around the interaction between mental disorders, stressful life events, and incident heart disease, as well as outcomes of heart disease. And, people who have a heart attack who've got a history of depression seem to do less well for whatever reasons. So there's something about that interaction and the interaction between, the mental disorders, which you might see as the sort of end of the final product of a pathline of adversity, but also the upstream adversities which happen, in earlier life.
And how about the question about the value of the linkages beyond the conventional medical records? So with educational databases, with potentially social databases?
Well, I think this is potentially very exciting. There's a question, I suppose, about how far there's a practical question in terms of the nature of the population for UK Biobank. In fact, in the centre I run, we've recently connected our mental health records with educational records. So the Department for Education has something called the National Pupil Database, which contains educational records for every child in the country. And you can look at their attainment from, the start of school right the way through to A-levels. You can look at adversities like the amount of absence they've had, so on. And actually it then gives us a very clear idea of the educational impacts of having a mental disorder, and also potentially what might change if you treat that disorder better. So I think these outcomes, if you're thinking about health in a more global, holistic way, you could also be thinking about, linking with Department for Work and Pensions data in terms of, occupational incapacity, and we're some way with discussions of doing that with our local health records. And I think that, you provided the consent within UK Biobank allows for that, I think it's a very helpful thing to do.
Thanks. And the next question is exactly on a wide-angle view of health. So the question comes from someone in the Met Office who asks, why are there not more studies linking to the environment and weather data? And I actually know that UK Biobank is working on that. Naomi, do you want to tackle that?
Yeah, so at the moment we don't have any information, well, we do have some information on environmental exposures. So in collaboration with colleagues from Imperial, we've got information on air pollution and noise pollution based on address at recruitment. And there are current research groups out there who are linking to other environmental data sets, such as temperature data from the Met Office, how close people live to the nearest park, to the nearest gym, to the beach, and so on, to give a more, if you like, global view of exposures. So that data is currently being worked on. And of course, part of the UK Biobank ethos is that all research results should be returned to UK Biobank. So that data will be returned to us and then made available for others to use.
And it's not theoretical, Liam, right? Some of your work has shown that there's strong correlations between temperature changes and cardiovascular disease, for example.
Yeah, we've shown very strong effects, actually, quite surprisingly strong effects for air pollution as a trigger of heart attacks. We've shown an effect of cold temperatures and even a very short-term effect of hot temperatures, all on heart attacks and indeed stroke. So these are certainly not theoretical things. Yeah.
So, Rory, could we have one final question? And then, yeah, it may come back to you again, Naomi. Will data on virus infections or viral infections, such as Hep C, HIV, hepatitis B, become available for UK Biobank? If so, what are the timelines for this?
Right, yeah. So at the moment, we have no data on, apart from when participants told us when they came into the clinic about virus infections. So what we would like to do in the future, if we get the funding for it, is to, from the participants' baseline blood sample, is to measure antibodies to a whole range of viral pathogens in the participants' blood. And that will give researchers an indication as to whether a participant has ever been exposed to a whole range of mainly viruses, but a couple of bacteria pathogens as well. So we're hopeful that that will become available in the next 3 or 4 years or so if we get the funding to do it.
Great. Maybe we'll give the last word to Kathy then, who described very nicely this big endeavor to bring and cross-reference various data sets together. Kathy, could you just maybe comment on where the process is for a couple of exemplar conditions for developing algorithms that cross-reference these databases that you've described that UK Biobank has achieved linkages with, what that cross-referencing is likely to do in terms of enhancing the validity of the diagnosis, and when that information will become actually available to users of UK Biobank?
Yeah, so I talked about phases of algorithm development earlier, and the algorithms that are most developed are those for two of the very commonest cardiovascular disorders, heart attack, MI, and stroke. And we've currently developed algorithms which combine data from self-report at baseline, hospital admissions data, both prior to and following recruitment to the study, and death registry data, because we have information across the whole cohort on those. And that enables us, using carefully selected codes where we understand approximately how well they perform, and we're doing extra work to understand that better, to construct variables, if you like, that allow us to say who has had a heart attack or a stroke prior to baseline, and approximately the confidence we have in that, and who has had a new heart attack or a stroke following their recruitment to the study based on those data sources. We've also, in our smaller proportion of about 27,000 individuals for whom we have had linkage to primary care data for a little while, enough to explore it, been able to look at the added value of primary care for those two disorders. And in a nutshell, it allows us to shrink, for those people who were recruited prior to baseline, the proportion of events that are available through self-report only, where the reliability is somewhat questionable. So quite a lot of those are then picked up through primary care, and we're able to confirm them, more for heart attack than for stroke, as it happens. And importantly, even more importantly, for incident events, it allows us to capture some additional events which are not captured through the hospital admissions or death data sets. For heart attack, most of which is admitted to hospital, it adds about 10% additional events. For stroke, it adds about half as many again. So about a third of all the stroke events are obtained through primary care only. So we add about 50% extra to the events that we detect through hospital admissions and deaths. Again, we think with reasonable accuracy, and we're working on these individual data sources using small-scale studies very similar to the one that you heard Tim Wilkinson describe for dementia, for MI, for stroke, and for a range of other disorders, just very much along the lines that Liam was suggesting, to try and understand where the events come from and how much we can rely on them.
Timelines?
Well, so the MI and stroke algorithms will be converted into data fields during the course of this year. So hopefully in the next release of Data Showcase in the summer or shortly after that, there'll be some data fields where people can go in and select prevalent or incident MI and stroke according to its origin. And then we'll update that when we have sufficient primary care data to add the added value of primary care. And towards the end of this year, we'll start to roll out that process to a range of other disorders that we're working on in parallel. Some musculoskeletal disorders, some respiratory disorders will probably be first. And potentially on the back of work that Matthew and his colleague Katrina Davis have done, some mental health disorders as well.
Great. Coffee time. Thank you.
Thank you very much.